We will be presenting a case of post-burn contracture of axilla today. A 40-year-old lady presented with a 40-year-old lady, nanny by occupation from Mednipur, West Bengal, presented with chief complaints of restriction in lifting her left shoulder and deformity of left breast since last 6 years. History of present illness. Patient who was apparently well sustained accidental flame burns while she was cooking 10 years back. Cooking flame was created by lighting leaves. A plastic rooftop in her house caught fire from it and fell on her. She sustained burns to left side of the neck, shoulder, and chest, also sustaining burns to both her hands while trying to remove the plastic sheet from her body. Immediate dousing of fire was done with water, done for around 10 to 20 minutes. She was admitted at a local hospital for a period of 8 days where resuscitation was done with IV fluids, medications, and regular close dressings were done. There's history of raw areas present over chest and near the shoulder at the time of discharge from the hospital. After a week, the patient started homeopathic and Ayurvedic medicine application over the wound, which led to gradual healing of the wounds over the next 6 months. There's no history of any splintage, physiotherapy, scar massage, or compression garments. There's history of difficulty in straightening her neck, moving her left shoulder with development of left breast deformity since 6 years. Patient underwent surgery for post-burn contracture of neck 6 years back at a different hospital, where she underwent incisional release and STSG, which is harvested from her left thigh, discharged after first dressing post-op, 1 week post-op, and there's no history of splintage or scar massage over the neck. Patient now presented to us with complaints of moving her left shoulder and lifting her left arm overhead with difficulty that has been progressively increasing. There's no history of there's history of difficulty in combing her hair and reaching objects at height with left arm. History of hypopigmentation in some areas of scarring, and there's no history of any itching, ulceration, or sinuses in the scarred area. Past history, there's no history of any significant comorbidities or any seizure disorder, no history of any surgeries done in the past, not on any regular medications, no history of any known allergies. Menstrual history, she attained menopause 2 years back. Obstetric history, parity index P2L2, abortion 1. There's no significant family history. Patient is non-vegetarian. Appetite is normal. Regular bowel and bladder habits. Sound sleep. No habituation to smoking, drugs, or alcohol. On general physical examination, patient was examined in a well-lit room with adequate privacy after taking consent. Patient is conscious, cooperative, well-oriented to time, place, and person. Moderately built and nourished with BMI being 25.68. There's no pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy, or edema. Vitals, pulse rate was 96 per minute, regular rhythm, normal volume and character. Blood pressure was 110 by 76 millimeter mercury, measured over the right upper arm in supine position. Respiratory rate was 20 per minute, regular rhythm. Temperature was normal. On head to foot examination, post-burn scar over the left abdomen and both hands were noted. Hyperpigmented scars over the anterior aspect of left thigh was also noted. Systemic examination, respiratory system, cardiovascular system, per abdomen, and central nervous system examination was found to be within normal limits.
Coming to the local examination, the patient was exposed till her waist region and was examined in standing position. On inspection, the attitude of her left upper limb was noted. The shoulder was adducted, elbow extended, forearm was in mid-prone position, and the hand was in neutral position. The extent of the scar was noted in the craniocaudal direction from the nape of the neck, left supraclavicular fossa, chest, till the inframammary fold. It extended in the mediolateral direction from the anterior midline across the chest, deltopectoral region, axilla, till the medial half of her anterior arm. There was a scar contracture which is present over the left deltopectoral region, extending across the anterior axillary fold and the medial part of axillary dome. Posterior axillary fold is not involved. And it also extended across the breast, distorting it superolaterally towards the axilla. The nipple areola complex is intact and noted to be 4 centimeters above the right nipple. There's a well-settled graft in the left side of neck with a linear scar band present along its anterior margin. The scar is not raised with pigmentation patches with no overlying pits or sinuses. On superficial palpation, there is no local rise in temperature or tenderness. The inspectory findings of size and extent were confirmed. The maximum dimensions of the scar was noted to be 29 into 18 centimeters. The extent of the scar was noted to be from the anterior midline till the mid-axillary line, from 2 centimeter posterior to the acromion process till 25 centimeter above the anterior superior iliac spine, and it was 10 centimeter proximal to the medial epicondyle on her arm. The scar is supple, smooth, and firm, with blanching present over the hypopigmentation areas. Touch and pain sensations are present over the scar. On palpation of the axillary pit, the summit could be accessed. We used a forceps for the same. There is no neurovascular deficit in her left upper limb. Coming to the movements, her right upper limb movements were all her right upper limb movements were recorded, followed by examination of the range of motion in her left upper limb. The abduction was noted to be 180 degree in her right upper limb, whereas it was 170 degree in her left upper limb. All the other movements of flexion, extension, internal, external rotation, and circumduction were within normal limits and equal on both the sides. Movements at elbow, forearm, wrist, and fingers and thumb were within normal limits. We assess the true defect using reference points of acromion process, anterior midline, the anterior superior iliac spine, the posterior axillary fold, and the medial epicondyle. So coming to our diagnosis, there is a 40-year-old with 10-year-old post-burn scar contracture involving the left infraclavicular deltopectoral region with left axilla, Kurtzman and Stern type 1A, and left breast contracture with hypopigmented patches in an operated case of split thickness skin grafting over the neck with an anterior scar band. Sir, should we continue with our management?
You can continue.
What is the duration of the post-burn?
10 years.
So, what is the possible causes of having a contracture, even if the patient was grafted initially?
Sir, as per her history, the patient underwent grafting. Following the first dressing, patient was discharged, and patient gave history that she did not undergo any further dressing care or any other physiotherapy or massage over the same. So she gave history that following the first dressing, she got discharged. And following that, her grafted area, as well as the other areas which were still granulating, they were all left open and they healed on its own. So there was lack of dressing as well as lack of post-healing management of the same scars in terms of physiotherapy, garment, splintage, massage, etc.
Can you please tell me the cause of hypopigmentation?
Sir, hypopigmentation, as we can see here in this case, sir, it is mostly in the center. These melanocytes, when they initially when in the second degree deep as well as the full thickness burns, the melanocytes get destroyed in the stratum corneum level. So when there is reepithelialization, these melanocytes, they migrate from the basal level towards the stratum corneum. But this distribution is always from the periphery towards the center. It is centripetal. So in this case as well, there has been some negligence, maybe because of that, because further massage and post-healing management was not done because of the reasons mentioned. The entire scar could not attain the same color as the periphery has.
So what is the basic difference between wound contraction and a contracture?
Wound contraction, sir, it's an active biological process that happens at the tissue level, as at the histiocyte level, wherein in the stage of remodeling of the wound healing, the fibroblasts and myofibroblasts, once they get differentiated, they start laying out collagen in bundles, which take time to get remodeled and get arranged in bundles, whereas contracture is an end result, or it's a pathological end result of these contraction, which can initially begin with some tightness, finally leading to functional impairment of that particular joint.
Do you get contracture over flat surfaces like your skull? There is a full thickness burn and the patient, do you get contracture over there?
Usually, sir, the contractures will be across joints, which in turn will lead to the either on the flexor or extensor aspect, which in turn will lead to the functional disability. But the contractures once formed, sir, they can extend, like it can become more severe, but not over flat surfaces as such.
Yeah. So now the patient, the wound has everything has healed, but why the patient has come to you again?
Sir, what she said is that she was having some difficulty, which she always had. She is actually a neglected, like she does not have any family member, and she could not come to the hospital even after the first surgery. So now, since last a few months, 6 months or so, it has started causing some tightness, because of which she finds difficult to comb her hair or lift her hand to get overhead objects. So that is why she has come late to us for these complaints.
Can you please elaborate on the movements actually? The restriction movements you have told. What are the range of movements?
Yes,
and
sir.
how they should be described?
Although, sir, she presented with a complaint of restriction in her left shoulder movement, on examination, we found that she is still able to abduct her left shoulder up to around 170 degrees. The main issue is only in the pulling of the in the shoulder region around the axilla because of the scar contracture. The other movements are flexion, extension, internal rotation, external rotation, and circumduction. So in internal rotation, sir, internal and external, we check the movement of the patient by telling the patient to keep her arms by the side of her trunk, and we tell her to basically move the elbow, move her forearms inwards and outwards, sir. Whereas in flexion and extension, we are in flexion, we reduce the scapulohumeral distance, where by asking the patient to cross her arm across her chest, whereas in extension, the distance between the scapulohumeral in circumduction, we ask the patient to outward stretch out their hands
Mute
and
someone, mute. There is some sound in between.
in circumduction, the patient is asked to outstretch her arm.
Dr. Om, we have to request Dr. Vidya to
Please mute Dr. Vidya. There is a voice. Speaker is on. Can you please mute Dr. Vidya?
can you mute from your admin side?
Sir, I'll just try, sir. Dr. Vidya, can you please mute yourself?
அது மட்டும் சாப்பிடுவாங்க பெரிய அண்ணன் பாருங்க ஆப்பிள் பனானா மேங்கோ ஆரஞ்சு கூடாது ஆப்பிள் இது வாழைப்பழம் இது மாம்பழம் ஆரஞ்சு இது தமிழ்ல வந்து மாதுளம் பழம்
Sir, should I continue?
Disturbance. But can you please continue?
Some disturbance.
Yeah. The admin should have a control over the
Can you
rest of
see
the
somebody
participants.
has to be muted for the disturbance?
Or you can
pineapple
remove the participant because as such she is not maybe listening to us.
Yeah.
You can remove a participant. I think that is also
Yeah,
possible.
can be done that way. Yeah.
Yes.
இது பப்பாயா பப்பாளி பழம் இது கோகனட் டெண்டர் கோகனட் தேங்காய் இளநீர் ஓகேவா
Dr. Ahana
Yes, sir.
Yeah, please continue.
sir is asking how to describe the range of motion. Is it something from minus to plus, or
Yeah.
is it?
there's a-
So sir is trying to ask you that.
இங்க பாருங்க செர்ரி
You have described already the range, but it is actually from the extreme of one motion to another motion.
ட்ரை ஃப்ரூட்ஸ்ல வந்து
Okay.
இங்க பாருங்க
And you should also tell how to measure these angles. Which instrument do you use?
Okay, sir. We used a goniometer, sir, for measuring. Wherein we used a goniometer, sir, for measuring. Wherein we initially the goniometer has two arms, sir. So we keep both the arms at the axis, and once the patient attains the maximum range of motion to her capacity, we basically raise one of the other arm and we check the angle in the same.
So as Dr. Manish has already told, it has a range and it varies from plus to minus. So what is the neutral axis? And depending on that axis, you describe your angles of movement from one extreme to the other extreme and say about the restrictions. What is the normal and what is the restricted movement? That way you can describe it in a better manner which everybody can understand.
Okay, sir. Okay, sir.
So Dr. Ahana,
Yes, sir.
couple of questions.
Yes, sir.
But you presented very well. I just wanted to know what was the problem with the patient in day-to-day life. That have you described that in history?
Yes,
What
sir.
problem she has? Maybe you can repeat
Yes,
that
sir.
again.
Yes, sir.
What problem did she have?
So she was
Okay,
actually,
yes, you said that combing
yes,
and teaching. So
Yeah.
could you notice a small contraction in the neck?
yes, sir.
What was that contracture? Is it an
Yes.
intrinsic contracture or an extrinsic contracture?
Sir, the patient did not mention that, sir, on history. We noticed it on examination. But sir, actually that contracture in the neck is not related to the primary event, sir. She underwent grafting over the neck. As we can see here, sir, she underwent grafting for what seems like there was some, she was developing contracture over the flexor aspect of over her neck, and she underwent just incision. From the history, what we made out is she underwent incisional release and grafting. Following that, again, she was not doing the proper care, so she started developing this. But the graft, definitely it is, we can see from the picture that it is in conjunction with the scar contracture. So we can say it is it has become like an extrinsic contracture also.
Okay. So do you think, and it is arising from axilla according to you?
No, sir, the band is over the neck, sir.
So why it is there? Because of shortage in the axilla skin, or is it due to actually the neck? How
Due
can
to
you
the
check
neck,
that?
due to the neck,
You-
sir.
Due to the neck?
Yes, sir.
So you,
We can make out here, sir. This band actually it is ending in the graft. It is not
okay. So what is the
can
better
you,
way is basically to, yes, yes.
this is the grafted region, sir. This smooth sheet, this was almost like a sheet graft. This is the band which is ending in the graft. So
Do you know how do you recruit skin and understand whether it is extrinsic or intrinsic contraction? Are you aware of that maneuver? That if you recruit some skin, you will come to know.
no, sir.
Are you aware of that?
No, sir. Sorry, sir.
It's okay, no problem. Okay, so how could you understand the depth of the burn? Is it involving the muscle? How do you know?
Sir, we check for the movement of that particular muscle. So in this region, we checked for pectoralis major.
Movement or contraction, or both? Are you talking about movement or contraction of muscle?
Contraction of muscle will be difficult, sir, to palpate because of the scar over the muscle. But we can assess if the pectoralis major is involved by asking the patient to medially rotate her shoulder and do adduction, which was not hampered in this case.
Did you try to feel the contraction
Yes,
of,
sir.
and what about the posterior axillary fold? Could you
Yes, sir.
feel the?
Yes, sir. It was posterior axillary fold was equal and equal on both sides. We compared it. We also compared the anterior axillary fold contraction, sir, on both sides. As such, there was no, we could not feel the pectoralis major per se, but she was able to medially rotate and adduct her shoulder.
Thank you, thank you.
Thank you,
Over
sir.
to other examiners or the moderator. You can carry on.
So should we go ahead with our investigations?
Carry on, carry on.
We would like to do a left shoulder X-ray, sir, anterior-posterior and lateral view to look for any signs of heterotopic ossification, since it's a long-standing 10-year history of post-burn scarring. And we would also like to do routine blood investigations with a chest X-ray and ECG for anesthetic clearance for surgery. The plan that we have for this patient is an incisional release with anterior fishtailing and darting in the periphery with partial excision of the hypopigmented scar, followed by split thickness skin graft with multiple Z-plasty for the scar band over the neck. This partial excision of hypopigmented scar, sir, we are not sure exactly how much scar needs to be excised. Partly it has to be excised, sir, because we feel that just an incisional release will not be able to bring the breast back to its normal position, bring the nipple areolar complex back to its position, sir. Thank you.
So what is the true defect? How will you measure it?
So true defect is a defect wherein we extrapolate the scar contracture on the normal side using bony prominences, measuring the distance of the scar contracture from bony prominences in every plane. So in this case, sir, initially the template that we had made, we have taken acromion process superiorly in the cranial direction, the anterior midline medially, the anterior superior iliac spine caudally, the posterior axillary fold posteriorly, and the medial epicondyle on the arm. Although using these bony prominences, we measure the distance of the contracture and we extrapolate them on the normal side, and then we shade the region and we get what is expected to be the true defect following release. However, sir, I
posterior axillary fold is a bony landmark. If the position might change on changing the position of the arm or
yes, sir.
shoulder.
Yes, sir. Sorry, posterior axillary fold is not a bony landmark, sir. But in this case, we decided to go ahead with it since it was not involved and completely free. So I would like to correct myself, bony landmarks or standard anatomical landmarks, sir. In this case, we took it because it was free.
So in a particular position, you have to qualify it. Because the position might change
Yes,
in
sir.
different.
Yes, sir. Sorry, sir. In the position of maximum contraction. So we basically asked the patient to abduct her shoulder to the maximum she can and then measure the distances.
So how are going to release it?
Sir, we would like to do a incisional release of the scar contracture with anterior fishtailing alone. Because as we can see here, sir, posteriorly, it is just about crossing the dome, but not completely involving the summit. So as we can show, if we just break it, it will give way. But we will be using darting incisions in the periphery. Along with that, sir, we might have to excise some more scar following release of to get the breast back to its normal position. Along with that, I'd like to go ahead with a split thickness skin graft over the defect. And for the neck band, sir, I would like to go ahead in the same sitting with a multiple Z plus T.
Is it incision or excision? Please qualify the statement. Incision release or excision release? Why incision and why excision at places?
Initially, sir, it has to be incisional release, but we will also be doing an excisional excision of the scar to get the final desired defect.
What is the basic difference? What is the basic difference between incision release and excision release?
In incisional release, sir, we make the contracture most visible by allowing maximum contracture, and then we place an incision at the highest point of tension over it to break the contracture and create the defect. In incisional release, per se, scar is not excised, but in excisional release of scar, excisional release of contracture, we release the contracture by excising the complete scar that has led to the contracture.
Which are the conditions where you go for incisional release and where you go for excisional release? There are certain conditions where it is mandatory to go for excision release. There is no way.
Yes, sir. Incisional release. Incisional release, sir, we do in cases of post-burn contracture of neck, or if a person has a flexion contracture across in IP joint of a finger, whereas excisional release, sir, when we find like a limited area of contracture where the whole scar per se is causing the contracture, in those areas we can cause excisional release of the contracture.
No. Please.
When the contraction,
Especially the pits and sinuses, presence of infection, presence of infected hair follicles.
Okay, sir.
So
yes, sir.
These things you under hypopigmented scar, your ample donor area. So you can excise everything and put multiple seat grafts. So why will you give your incision?
where? At the site of maximum tension, sir. At
So
the
how
site
you
of
know that it is the site of maximum tension?
in this case, sir, we have to place the upper limb in maximum abduction possible, and at the area of maximum tension, we will place the incision.
So can you show the incision which you have planned in your one of the pictures?
So here is the incision. Are you able to see our pointer, sir? Visible to me.
Is this just one line or?
No, sir. It posteriorly we will be in this case, sir, this towards the posterior side.
So is it just one line or is there some modification?
Yes, sir, there will be a modification, sir. This is going to be the first line, sir. That will be the first
Yes.
incision. And this
Okay.
will be having an anterior fishtailing. This we have drawn it only till here, but we might have to extend it some more. Once the first incision is taken, sir, and we break the fibrotic bands, we are expecting that the arm will be released and we will have to be giving darting incisions along the periphery, sir. So once the arm opens, we are expecting that there is going to be a two-dimensional, it will be a rectangular defect, which will be required to elongate more using darting incision, sir. And that is why at that time we are expecting that our incision will be even extending in this region more medially, allowing us to get the NAC back to the position, normal position.
Dr. Anna, can you show me the diagnosis again?
Yes, sir.
So you say the left breast contracture was also there,
Yes, sir.
which we can see very clearly. But once you marked, and you said that for marking you use the bony point or the fixed anatomical points. Don't you think nipple was an anatomical point which you should have considered to measure the defect? I think you have missed the defect. You have calculated the defect very less. That's why if you add mark nipple also, you can, there's a huge defect which you did not measure.
Yes, sir. Yes, sir. Yes, sir. To answer both your questions, sir, firstly, the reason why we did not take the nipple, sir, is because the nipple is not in its normal anatomical position. So we
On
decided.
the other side, when you mark on the
Other
other side, it's a normal position.
Okay. Sorry, sir. And secondly, sir, the defect that we. This true defect that we made, sir, as I mentioned, sir, earlier, this is what we got only by these points. So we are expecting it to be more. So yes, sir, if we would have taken the other nipple, it would have been more. Yes, sir. Sorry, sir.
Okay, no, it's okay, no problem. Okay, so, okay, and then sir has absolutely covered most of the things. Why will you not try to cover with the flap? Do you think patient is alone? She be able to, follow all your instructions if you again put a graft? I would not use STIG as a first choice if you give me that type of picture for the patient. So what are the advantages of STSG and why will you not, and what are the advantages of a flap? And what flap will you use in case you decide to use a flap?
Sir, the disadvantage of split thickness skin graft over flap would be that it would require us to splint the patient for a longer duration of time, which will not be required if we take do a flap. However, sir, in this case, we feel that a flap will lead to it might give a more bulky appearance over the region, because of which we want to go ahead with grafting of the area. Grafting will give it a more supple area, and looking at the patient, she seems more motivated, so she can go ahead with longer duration of splinting as well. The second reason, sir, why we did not go ahead with a flap in the first choice was because in this case, if we go for a pedicled flap, our first two choices would be, first choice would be a parascapular flap. But looking, if you can see here, sir, the after release, we are expecting that this axillary part is going to be free. So we might have to dissect the pedicle of the flap up till its origin, that parascapular flap, up till the circumflex scapular origin. Even if required, we might have to go till the subscapular level. So it is possible, sir. It is definitely possible, but it might be more tedious. Free flap, yes, can be done, sir. But I would like to go ahead with my first choice as a skin grafting.
Okay. Okay. Fine. And other examiners want to ask anything, or should we continue? Angeline ma'am?
Can continue, sir. Can continue.
Okay, okay. So if you want to use a free flap, what free flap will you use?
Sir, I'd like to go ahead with the anterolateral thigh free flap, sir.
So do you think it is a good flap? It may be very bulky, especially in females. There's a lot of thigh in that, lot of fat in that area. She appears to be, I feel that there was a lot of fat, very bulky flap. You said parascapular is a good choice. I think pedicle or free.
Yes, sir.
Parascapular is a very good
Yes.
choice. And
Yes, sir.
okay, and you can use, okay, so flaps we don't use, as you all know, flaps we don't use because we don't want axial area to be bulky. So it is an advantage and it is a disadvantage. We need to have a prolonged splintage. And was this axilla and neck grafted in the same sitting, or they were differently sitting graft? Differently.
So she did not undergo any grafting, any management for the axillary contracture, sir. She only underwent grafting over the neck.
After the first graft dressing, she was discharged and then it was not dressed again. You said that. So I thought
Yes,
it was
sir.
grafted.
Yes, sir. Only
Was
the neck.
Axilla was grafted or not?
No, sir.
Never. Okay. And what about any hand contracture? Did you examine both the hands?
Yes, sir. We did, sir. We did not go into the details of it, but we did examine. She, on her right hand, sir, she has a boutonniere deformity of her right fourth and fifth finger. And she has, in her left hand, there is a web creep, which is present in her second, third, and fourth web spaces.
Okay, we'll not go into the detail. Suppose she has a neck contracture also. Can you release both of them together in same sitting? Again, as you said, that patient is coming after 10 years. So she may not come again to you. So would you like to release the neck and axilla in the same sitting in case you have both the contractures?
If both the contractures are released in the neck as well as the axilla, sir, post-operative splintage will be difficult to maintain.
Why?
Neck should be maintained in extension and as well as the axilla.
Axilla has to be abduction, sir, of at least 110 degrees. But in case like this, sir, if we are doing a local flap, such as what we are proposing in this case, then flap for the neck and graft for the axilla can be done. Because if we put a flap over the neck, it will not require, such as a local flap, sir, it will not require that much, or any flap, it will not require that much duration of splinting. So 3 weeks should be fine, sir. But in STSG, we have to give at least 3 months of continuous 24/7 splinting, followed by 6 months of night splinting. So in those cases, we can do, sir, depending on the severity of both the neck and the axillary contracture. But if the neck contracture is, if both are equally severe, sir, then first we should give definitely priority more to the neck.
Why?
Because, sir, neck post-burn contracture of neck, it will have effect on her breathing. Breathing difficulty might be there. So neck is an important is aesthetic as well as a functional unit, sir. We have to release
Basically,
it.
there's a repeated risk of during the intubation. The anesthesia process becomes safer next time.
Yes,
So
sir.
that we will always prefer to have a neck in, usually in all type of burn contractures. Okay,
Yes, sir. Thank you, sir.
fine. And what splintage will you use? What is the splint what we use for these type of contractures?
For
What
the
are
auxiliary
those? Yes.
aeroplane splint, sir, is one of the splints that can be used. Initially, immediate after the surgery, we usually we go for a POP, plaster of Paris splinting, wherein we maintain the upper limb in abduction. Following that, sir, after the first dressing at post-op day 5, we go ahead with an aeroplane splint, which usually here in our institute, we go for a customized prefabricated splint, which keeps the upper limb, the shoulder abducted to at least 110 degree. Till
Okay, so what are
wherever we have achieved the release.
So after the cleaning draping, you will do some injection or something?
Yes, sir. Sir,
What do you inject and how do you inject?
Sir, we usually use adrenaline solution, sir, here. 1:1 lakh concentration, sir. We use it as a tumescent, so it not only helps in controlling prolonged action over the bleeding, it also creates a plane so that it is easier once we are releasing the fibrotic bands. The separation gets easier just underneath the bands.
So what
So
dose?
here our target is
dose
still
will
the
you-
pectoral fascia.
What is
Dose, sir,
what ml will you give in her? How much ml of Adrenaline 30 ml? You know you have a 30 ml vial, na? So how much Adrenaline can you give to this patient? Approximately, roughly.
sir, actually, we here use like only adrenaline, sir. 1 milligram, 1 ml, 1 ampule we use in 100 ml of in 1:1000 we use in 100 ml of
Okay.
so we get a 1 in 1 lakh ADR solution.
Okay, it's okay, no problem, no problem. So, okay, I think Dr. Vishal and Madam can ask. I think we have Dr. Umar. You can invite other examiners?
Yes,
I think
sir. Dr. Angeline, madam, and Dr. Vishal can join, please. Join the other panelists, ma'am.
Dr. Anna,
Yes, sir.
which type of graft you use? Which type of graft?
Madam is there?
Yes, sir, I'm there.
Yes, ma'am. Please, you can join Dr. Satya.
Sir,
When you are making,
Yeah. Please.
Madam,
sir,
please.
Sir, I'd like to go ahead.
sir
with-
had asked the question of about the graft, what type
Yes,
of
yes,
graft you
sir,
are.
sir, will continue, you will join. Yeah, ma'am.
Sir, I'd like to go ahead with an intermediate thickness, split thickness skin grafting with minimal meshing.
Why can't you use full thickness graft?
Sir, full thickness, in her case, sir, I am expecting a big area, sir. So the donor area for the full thickness skin graft might be an issue, sir. It can be used, but intermediate thickness, split thickness skin graft, if taken and taken care of well post-operatively also, then I am okay with using that.
Is there any way that you can think about taking a full thickness graft or something of that equivalent?
Skin substitutes, sir?
If we use a
Can you name a few
matrix
of them?
along with the split thickness skin graft, such as Integra and Matriderm, sir. Integra is it's a composite structure which has silicon in the
What is
periphery.
DRT?
Dermal template. I'm not sure, sir. Sorry.
Sorry, DRT. R is regeneration.
Okay, dermal regeneration templates.
Yeah.
So in Integra, sir, it is it has silicon on the outer side and it has bovine collagen and sharp chondroitin sulfate. So Matriderm is the principle is the same, sir. They basically provide a scaffold for the that acts as a dermal template. This leads to better collagen remodeling, and it also creates a new neodermis over which the graft can settle well, sir. So most of these, they have pores in between, so the capillaries can traverse these dermal templates and provide nutrition to the skin graft during the initial phases, as well as once the neovascularization sets in.
Do you think you can release the breast and do it at the same sitting? Will you be able to bring the breast to its normal position by your axillary release?
Yes, ma'am. We think it is possible, ma'am, in the same sitting.
What should you do then? What will be the extension that you have to do that? Get that.
Yes, ma'am. So our plan is, ma'am, that we will give the incisional release, and once the tissue gives way and the defect starts forming, ma'am, we will go on making darting incisions, as well as we excise part of the medial scar as well. We will try to encompass it over the hypopigmented region, so that will
What will be your comparative landmark?
The nipple on the opposite side, ma'am.
Yes, yes. You're going to release it as long as it is going to come down. What may be involved? That is just the breast tissue or something else you expect may be involved in it when you're releasing. What is underlying the breast?
The breast.
Lactiferous ducts, ma'am.
No, breast as a whole, below the breast. Retromammary area, what will you have?
The muscle, ma'am.
What muscle?
Pectoralis major.
What will be there? What may be the limiting factor to pull this amount of breast tissue upward? What is the fascia that is there?
The pectoral fascia.
You may have to give an incision in the pectoral fascia also to release it. So will it be an advantage making an incision over the pectoral fascia and grafting, or just covering the breast alone with a graft? What will have a better graft take?
Definitely, ma'am. Incising the pectoral fascia and grafting will lead to better result, ma'am. If we can place it directly over the muscle, we should cut the.
Okay. Again, how will you do the dressing after you release it?
Post-operatively.
Immediate post-op, you're going to release, apply the graft, and you're going to anchor. How are you going to apply the dressing?
Yes, ma'am. We would be using quilting sutures, as well as we will go ahead with a bolster dressing. We will use 2-0 or 2-0 silk to at symmetrical opposite points, at least in 3 to 4 sections, which will and with adequate fluffy cotton, we will be putting a bolster dressing.
So that the breast is kept at a lower level, and then you go ahead with your POP or your splint to keep the upper limb shoulder at 110 degrees. Okay. Sir, anybody else who wants to question?
Hi, sir. Can you tell me modern method of immobilization of the grafts, especially in uneven surfaces like this?
Sir, NPWT, negative pressure wound therapy, can be done over grafts. That especially helps and gives more consistent results if used over uneven surfaces, because we are creating a vacuum effect over the graft.
Yes, thank you. What is the essential difference between fistula and darting? Why do you use fistuling?
Sir, like we use fishtailing in finger contractures. So if we have a post
Here only, just in this context.
in this context, sir, and anteriorly, that is towards the acromion process, I want to go ahead with the fishtailing, sir. But fishtailing, when we do, it has to be at the ends of the incision. So it has to be consistently taken at that layer only. In this case particularly, where we are not exactly, we have to cut as we go and decide where exactly we have to cut the scar more. In these cases, darting helps. So darting are incisions which are taken at random areas at the periphery of the scar, in those regions where we are finding the pull more. So as and when the contracture starts releasing, the pull of the skin will enable us to make the incision over that particular area. So this is the advantage of darting over fishtailing in these cases, these sort of cases.
Essentially, fishtailing is done at the end of your incisional release. But fishtail, you can give the darting incision you can give while there is facing some contracture band and all. So it is cut as you go. That's good. And basic purpose of all these incisions, why after all they are needed?
We are making the defect, sir. We are making it from. Firstly, there are two reasons, sir. One is that it will the defect becomes more trapezoidal than elliptical. And secondly, it helps in preventing recontracture, sir. When we give these peripheral incisions, the release is more and we can get a more complete release of the contracture.
Mostly it is the contracture force is your centripetal. So you want to make it more elliptical thing, you can make it more rectangular, or you want to tend to feed more grafts, make it a centrifugal force like that. So tend to feed more grafts into the defects which you have created. So that's the purpose. At least you tend to release it liberally, so that you tend to feed more grafts. So tell me about the postoperative care.
Post-operative care, sir, we would be at immediate post-op, we would be shifting the patient with her upper limb abducted, shoulder abducted with a POP in situ. Patient will have to maintain that position, sir. From post-operative day one, she can sit and mobilize as well, sir. We will be doing the first dressing on post-operative day 5, wherein we will be cutting the sutures of the tie-over dressing and examining the wound. And following that, we would be doing regular dressings of the wound. The splintage has to be provided for at least 3 months continuously, followed by 6 months of night splinting. From 3 weeks onwards, I'd like to add for her, especially since her chest area is also involved, I'll have to encourage her to wear compression garments to start once the graft starts settling in from 2 to 3 weeks onwards. Proper coconut oil massage, following the cleaning of the wounds, and even silicone gel if possible, along with physiotherapy. So while she has the splintage, we would be initially beginning only a few, like every 3 to 4 hours every day. Following that, we would be repositioning the splintage back. After around 2 months, sir, we'll continue increasing the frequency of her shoulder exercises, but splintage has to be continued along with physiotherapy.
Thank you.
So can we go ahead with the next session, sir?
Yes, please. Our time is up. So we can go with the next session. Lord Likhtar.
So the next session is questions by other teams. I'll call out the team names. The participants can please start asking questions. Team 1, Madras Medical College.
I think they are absent.
Yes, sir. Team 2, JIPMA.
Hello.
Hello.
My question is, could you just highlight the principles of release of axillary contracture?
The first principle would be that we need to achieve a shoulder abduction of at least 110 degrees. The axillary dome should not be displaced, especially the axillary hair should not be misplaced, because that will lead to further, it will look odd, might require reconstruction later on. We have to maintain the anterior as well as posterior axillary fold boundaries. Breast, in females, the breast deformity should also be corrected as much as possible. We have to attempt to do it in the first sitting.
Okay. Anything else you'd like to add?
We have to go till the pectoral fascia to release.
Okay. Thank you.
Team 3, KGMC Lucknow.
Hello. What is the difference between contraction and contracture?
Contraction is basically a biological process of healing when full thickness burns has occurred. It is a nature's way of healing, and contracture is a result of contraction.
Okay.
Team 4, Stanley. Stanley Medical College. Team 5, AIMS Delhi.
Good evening, everyone. Can you describe axillary contracture classification based on extent of scar?
Sorry, I did not hear you. Axillary contracture based on?
Extent of scar.
Extent of scar, Kurtzman and are you implying the Kurtzman and Stern classification? That is 1A is for the anterior axillary fold involvement, 1B for the posterior axillary fold involvement. 2 is when both of them are involved, and 3 is when the axillary dome is also involved. There are other classifications as well, such as there is a Macaulay classification where he has graded the severity of the contracture as well.
There's one more by name Toet and Bossy classification. Can you describe that?
No.
Okay, it says type 1 is both anterior and posterior axillary folds are involved, leaving the normal skin in the hair-bearing central part, and a web is formed during abduction. Then type 2 is the inner portion of upper arm and adjacent trunk, as well as one axillary fold is involved. Type 3 is upper arm and lateral aspect of the trunk and completely included in one mass of U-shaped hypertrophic scar. So these three are there in Toet and Bossy classification, and it takes into consideration the angle of abduction. Based on that, how much will be the skin deficiency that will be present. That is, the angle of abduction is less, the skin deficiency will be more. So they measure from the tip of the middle finger to the axillary pit, and then that is line A. Then line B will be from the axillary pit to the ASIS. So if you add that, it should be equal, like normally, if there is full range of abduction, it is the A plus B is equal to the whole range of abduction. So like that. Thank you.
Thank you.
Team 6, Bangalore Medical College. Bangalore Medical College. Team
Absent?
7,
They're absent.
yes, sir. Team 7, CMC Vellore. Team 8, Safdarjung.
Good evening. What can you tell me about the management of hypertrophic scars using laser therapy?
Uh, So we have to address different parameters when we want to address scar with laser. So one would be the pigmentation aspect. So for pigmentation, usually you asked hypertrophic scars. So for hypertrophic scar, which are usually on the hyperpigmented side of the spectrum, we have to go for IPL laser as well as pulse diode laser. Along with that, if there are hypopigmentation areas, we might have to use Soralin and UVB rays as well. For the texture, for ablation, we have to go for, usually we use carbon dioxide laser, which will also help in the texture management as well as for resurfacing, decreasing the height of the scars.
And do you know the wavelength of these said lasers?
For the IPL, it is around 500 to 577 to 700 is the spectrum. I'm not exactly sure of the correct numbers.
The pulse star is actually around 585 to 595. And for ablative scars, for ablation purposes, we usually use
1,000, more than 1,000.
It's carbon dioxide, which is around 600.
Oh.
Thank you.
Next team.
Sorry, Team 9, RML Medical College. Team 10, Keelpock Medical College.
Good evening, ma'am. Can you please tell the thickness and name of the thin, intermediate, and thick split thickness skin grafts?
You want the sizes?
Sizes and the names, the associate, the scientists for the doctor.
Ultra thin is 0.03 to 0.05 inches. I'll be telling in inches. That's then thin is 0.08 to 0.10. Medium is 0.10 to 0.15, and more than that would be thick. Names not
Full thickness is wolf's graft.
I've asked for the split thickness.
He's
Split
asking
thickness, thick is
different types.
Paget. Intermediate is Blair and Brown, and thin is Thiersch and Olier. Thank you.
Thank you.
Team 11, Gandhi Medical College.
Hi, good evening. So my question is, what are the 3 anatomical spaces in the axilla, and which space is related to parascapular flap, and mention its boundaries and its significance?
There's a quadrangular space, upper and lower triangular space. Lower triangular space is also called as triangular interval. So the quadrangular space is formed superiorly by the teres minor, inferiorly by the teres major, medially by the long head of triceps, and laterally by the humerus. The upper triangular space is from where we get the origin of circumflex scapula from subscapular artery, which comes from third part of axillary artery. So that is basically medially, superiorly by the teres minor, inferiorly by the teres major, and medially by the long head of triceps.
Yes, correct answer. Thank you.
Team 12, Mamsi, Delhi. Team 13, NIMS, Hyderabad. Team 14, Ganga Hospital, Coimbatore. Team 16, AIMS, Rishikesh.
Good evening. My question is, you mentioned Z-plasty. I would like to know the ratio of gain in length compared to with respect to the angle of between the Z lengths. If you can enlist at which angle you get how much gain in length.
Sorry, 500, 7,500. At 60 degree, we get a 75% gain, and 75 degree, we get a 100% gain.
45
the
degree,
length.
it will be 50%.
Okay, and in this case, how did you plan it?
We went ahead with a multiple Z-plasty. So we we took one in the middle and we went ahead with 60 degree. We could achieve it.
Okay, so you gained the adequate length that was required in full extension with 60 degrees.
Yes.
Okay, thank you.
Can we go to the next session, sir?
Yes, please.
All the team.
Case 1 is a case of unilateral lower limb lymphedema, most likely lymphedema, as we can see a dorsal hump over the foot. So I'm assuming that it should be stage 2, or it should be stage 2 according to the International Society of Lymphology classification. And case 2, in case 2, I can see skin changes along with that hyperkeratosis. Skin features are being seen. So it most likely is stage 3 lymphedema of left lower limb.
Case 2 looks to be having more permanent changes because the skin appears to be more thickened, and there are the trabeculations, and this is mostly stage 3 according to international classification. It would be stage 3.
Can you please elaborate those stages?
So stage 0 is subclinical. When
You are not audible, please. You are not audible.
There is some problem with their network, I think.
Okay.
Ahana, Dr. Gopika?
edema will be, lymphedema will be reduced. And stage 2 is when
Please,
there is.
Dr. Gopika, you repeat because you were not audible in
So
between.
now, sir, can you?
Is it audible now, sir?
Yeah, it is audible. Yeah, please go ahead.
Now you are audible. You start anew.
Okay. Stage 0 is subclinical stage. And stage 1 is when there is spontaneous resolution seen. And that is when the patient elevates the lower limb, the symptoms subside. And stage 2 is when there is irreversible lymphedema. And stage 3 is when the skin changes occur. That is lymphostatic elephantiasis stage.
Just can you describe what is lymphedema?
It is a subcutaneous accumulation of the fluid in the interstitial space.
With some chronic inflammation.
Yes.
What are the possible causes?
It can be infectious causes, like most common being filariasis in our country. It can be post-traumatic, post-surgical, after lymph node
dissection. So these, what she mentioned, were the secondary causes of secondary lymphedema. There's also a component of primary lymphedema, which is lymphedema precox, congenital lymphedema precox, and tarda. So congenital is seen immediately at birth. Then Recox is seen from
35 years.
35 years, and post 35 years we see Tarda. So in these cases, there is no per se secondary cause of the lymphedema. There is congenital hypoplasia or aplasia of the lymphatic channels.
So how do you diagnose?
Clinical diagnosis can be done, sir. Clinically, we find a dorsal hump over the foot, stemmer sign, and ability to pinch the skin over the dorsum of second toe, and then as per investigations, lymphoscintigraphy imaging can be done. Water displacement is not done these days, but it is a reliable method.
Lymphoscintigraphy, sir, is the preferred mode of investigation of choice in current scenario, because it will give us an idea of the status of the lymphatic channels, but it carries the disadvantage of having radiation exposure. So the most recent investigation would be using ICG and using a gamma camera, lymphography using the same. So although there is no radiation exposure in that, but we do have to inject the dye in the second web space in such cases.
Along with that, clinically, we can assess the circumferential girth of the lower limb and compare it with the normal lower limb.
And it also gives us a real-time imaging of the lymphatic channels, as the dye can be seen in real time traversing and going in retrograde manner towards the lymph nodes. So we can also segregate the lymphedema based on the severity, based on where dermal flare or reticular veins are seen more, where collaterals or backflow is seen more. So depending on these signs, we can also get a better idea about the severity of the lymphedema.
What are the basic investigations you would like to do in this patient? Because you said that reasons are, that is, etiology is different. Don't you want to think of other etiology for which you have to investigate?
Yes, ma'am.
Ma'am, can you start the video also, Anjali ma'am? Yeah, ma'am. Thank you.
So what we mentioned, ma'am, were the imaging modalities. We would, especially in our country, we would also like to confirm the cause of the etiology of the lymphedema by doing a peripheral smear to look for the filarial parasite in the smear. Usually a midnight sample of the blood is taken. Along with that,
and what type of smear it is? Is there a specific name given to that smear, or what type of smear? You take a thin smear or some thick smear?
Thin smear, ma'am.
It's a thick smear. It's a thick smear.
Sorry, ma'am.
It's a thick smear, midnight usually. Okay.
Along with that, now we can also check for the immunoglobulins, ma'am, IgG, IgM, especially depending if the patient has had a recent episode of lymphangitis, then IgM will be raised.
Basic total count, differential count. What will be the changes in the
total count will be raised, ma'am, if there is a lymphangitis episode, but if it is just lymphedema as such, it will not be that raised. ESR, although ESR and CRP
What
might
about the eosinophils?
Eosinophilic count will be more, ma'am.
That is a significant finding that you will get. A significant eosinophilia is suggestive of your filarial lymphangitis. Okay. Go ahead.
So, what is your diagnosis for case 1?
Sir, this would be stage 1 lymphedema of the left lower limb.
Why it is not a lipedema?
Sir, from this photograph alone, we might not be able to.
You are telling by photograph it is lymphedema, so
Yes,
we are
sir.
just
Yes, sir.
photograph
It can
only.
be. Yes, sir. Yes, sir. Sorry. Yes, sir. It can be.
What will you, again, if I want to say that it is lymphedema, then what this picture has difference between lipedema and lymphedema, which you want, then you can understand.
Sir, means to say, how will you differentiate between the two? Right, sir?
Yes, yes.
How will you
On this
differentiate?
photograph, I can ask because stemmer, they told the stemmer, but they can't pinch right now. You can't pinch, so stemmer is
Dorsal part of the foot is not usually involved in lipedema.
What is that known as? You know what is the cuff sign? Cuff sign. You know what is the lipedema cuff sign? So it will end at the ankle. You know the wrist cuff?
Okay, sir.
It will, in arms, it will end at the cuff. So if you can see the dorsal edema bit, then it goes in favor of lymphedema. If the dorsum is so, here you can somehow, by the way, plus minus say the dorsum has some edema, but you can see the cuff also. If we see is trying to limit at the cuff. So I have points in favor of lipedema also in this particular case. Sir, Umar sir, you were saying something.
I was saying just how can you differentiate? We can move to the next. I think 10 minutes is gone for this session.
So you should always, Ahana, you should always put a DD. You cannot put only one diagnosis. Better to put a DD, and that is a good idea.
Okay, sir.
Okay.
Thank you.
Next.
Yes.
Dr. Hana, why the soul is not involved usually? Very rare. You see any grade 4 or anything, soul is paired. Why? And number 2 is what is lymphangiectasis, which mimics like lymphedema on photograph.
Sir, the first question, sir, the dorsal skin is more loose. Whereas the sole is more adherent, the skin is more adherent. So if the lymphatic fluid, it has to accumulate in the interstitium. So because of that, that could be a cause for why the dorsum of the foot is affected and not the sole.
Okay, I'll answer later.
Okay, sir. And lymphangiectasis is no, sir. We are not sure, sir.
Okay, no problem.
So time for this session is over, sir. Can we go to the
Quickly
next?
tell about the options of treatment. Okay.
So they can answer. If you have an answer, can you
Next
please answer quickly?
What was it, sir? Pardon.
CDT. Tell them about CDT.
Complex decongestive therapy, sir. It has having basically 2 stages of manual lymphatic drainage. There's an intensive phase, which usually is done in hospital for around 2 weeks.
You know about it. Just go ahead. Next session. You know, I got it. So surgical options quickly. Then before go to next.
Surgical options, sir. It would include there are excisional surgeries and physiological surgeries. So excisional surgeries include like Sistrunk, Thompson, Homan, and Charles, whereas physiological surgeries are depending on the cause. We can do either if depending on the etiology. Suppose if the lymphatic channels are injured, then usually we do a vascularized lymph node transfer, or we can go for a free flap, such as a submental flap, wherein we do a microsurgical free flap put it in the dorsum in the foot, or we can also do lymphaticovenular or lymphatico-anastomosis if that is super microsurgery. That is if that can also be done.
Okay, thank you. Go to the next session.
Next week.
Read the.
Yes, sir.
So this is a case of 3D reconstruction of computer tomography of the skull, showing right-sided fracture over the frontal process of the zygoma, the temporal process as well as the maxillary process of the zygoma. So this will be a right-sided zygomatic fracture involving the zygomatico-temporal and zygomatico-maxillary sutures, which is
What is night and north classification of this?
night and north classification, ma'am. First is which is not the fractures which is not displaced. One.
Okay.
Second, two is
Mm.
the arch is involved, ma'am, and three is fracture which is not rotated, and four is medially rotated, five is laterally rotated.
Yes. Okay. Six is additional fractures.
Additional.
Okay. So under which classification will this be?
So, this zygomatic arch is involved. Arch is involved in type 2. Medial rotation. Medial rotation. Type 3, ma'am.
Yeah. Okay. Displaced body. Is it rotated or unrotated?
Medially rotated.
Then it becomes type 4. When you say it is medially rotated, it becomes type 4.
Excellent.
Okay. What will be the clinical feature?
Clinical feature, ma'am, malar area flattening will be there. In subconjunctival hemorrhage can occur.
Okay.
Infraorbital area paresthesia can be there.
Okay.
Deformity on palpation. Periorbital edema. Since the arch is involved, trismus
Okay.
can.
Okay. Trismus. What are the other views of X-rays that you take? Usually X-ray views. What are the views that you take for a fracture of to find the fracture of zygoma? What is Waters' view? What is Waters' view? Is it anteroposterior?
I'm not sure.
Occipito?
Front.
Occipito-mental 45-degree angle view is called as a Waters' view.
Okay.
What is Caldwell's? Caldwell. That is a Caldwell view is a PA view.
Okay.
PA view, posterior anterior view is Caldwell. Okay. So, any test that you would like to do in this person? You said subconjunctival hemorrhage is there. Any other finding in the eye may be there?
Force duction test to check for entrapment of any muscles, extraocular muscles.
Which muscle will be involved? What will be trapped?
Lateral rectus muscle.
How do you do the force duction test?
After instilling anesthetic drops over the eyeball, we with the forceps we try to mobilize the eyeball in all directions. Then if there's any restriction of movement.
Okay. When will the person develop diplopia?
When the floor of orbit is involved, ma'am.
What mean that is when you are, when he tries to see in which direction there will be diplopia.
Laterally, ma'am. I
Laterally
mean,
or
on the right side.
when he tries to look downwards or upwards?
Upwards, since the muscle is entrapped in the floor.
There are others. What are the other?
Sorry, ma'am.
How will you manage this patient? He has got fracture in all the three buttresses. Does he require surgery or conservative management?
He requires surgery, ma'am, to maintain all the buttresses. It is required. So
Okay.
have to fix the zygomatico-frontal zygomatic arch as well as the zygomatico-maxillary processes with plates and screws. And
Okay.
If
First, before you fix, what should you do?
intermaxillary fixations, ma'am.
No. Before you fix, will you reduce the fracture? How do you reduce the fracture? How do you reduce the zygomatic fracture? What are the ways you do a reduction of the zygomatic fracture?
Gillies approach is there, ma'am, to manipulate the zygomatic arch. So around 2.5 centimeter antros superior to the helix, we take an incision, and through that incision, we try to manipulate.
To what level you make the incision in that?
5 centimeters.
In what plane you enter into the? No, I'm not asking the centimeters. In what plane?
Deep to the deep temporal fascia.
Okay. What is the principle?
It's a lever.
How will it reduce, ma'am? How does it act as a? Where is the insertion of the temporal fascia and where is the insertion of your temporalis muscle?
Temporal fascia, ma'am.
That is the basis on which you use it as a.
Temporalis muscle, it gets inserted into the coronoid process. Temporalis fascia, it splits into the deep temporal fascia, it splits into two, and on either the outer and inner borders of the zygomatic arch, it gets inserted.
Once we make the incision, ma'am, and we place the.
So using that as a lever, want to reduce it.
There is another arm which is outside, which is basically corresponding to the arm that has gone inside through the incision at the same length. So that will give us an idea at what level it is. Interior side.
Okay. So when will you know that it is reduced? You hear a
sound.
How will you know you're reduced it?
We can click somewhere.
Okay. And how do you fix? Where do you fix? And how do you fix?
Across the sutures, ma'am, across the zygomatico-frontal, zygomatico-maxillary, and the temporal process of the zygoma.
If the patient already has an incision on the skin at
Minimum 2 places.
Ma'am, your audio is not clear. Sorry.
I think, I don't know whether my I'm not sure whether my network is not clear. I'm not able to hear you people.
Not audible, ma'am, please.
Please others carry on because my network seems to be unsteady.
What is teardrop sign?
Teardrop sign, sir, it is seen in CT scan once when in cases of floor of orbit fracture where there is a displacement of the eyeball in the maxillary sinus, sir. It looks like a teardrop. It can be visible in CT and sometimes in X-ray as well, sir.
How do you manage this one? What is it? It is called?
Lead to amblyopia.
Diplopia.
It will lead to diplopia because the eyeball. So, sir, that is an emergency, sir. We have to reduce the fracture and we have to reconstruct the floor of the orbit. So, in case there are fractured, usually we will be placing a titanium mesh, or we have to reconstruct the floor of the orbit and fix it after replacing the eyeball back into the orbit.
Can you tell me a modern method of fixing this type of fractures?
Endoscopic.
Oh, it is 3D navigation. Because the real danger is the nerve, optical nerve, no? Optic nerve. To safeguard it, you have to use that 3D navigation. You have to see the position of the nerve because that placing the mesh in the floor of the.
So, time is up, sir. Can we go to the next session?
Yeah, sure. Thank you. Please go ahead. Left uppermost.
Sir, these are a set of hand splints. In the top left corner, we can see a knuckle bender splint, which is keeping the hand in intrinsic plus position. These can be used in claw hand as well as following post-burn contractures of hand in order to keep the MCPJ in flexion and the IPJ in at 0 degrees. I mean, with full extension. This basically it's a dynamic splint which will keep the hand in functional position, allowing the patient to move the fingers as well as to prevent contractures. The second one in the top row, sir, it is a volar splint, which volar cock-up splint, which looks like static. It has
Yes, go ahead. What is the purpose of this splint?
Yes, sir. So the second splint, sir, it would be used for flexion when there are burns over the palmar aspect of the hand or the flexor aspect of the fingers. Or trauma, or this can be just following trauma, sir, like a universal, to keep it in the position of safe immobilization. The third splint, sir.
What is that position of immobilization and what is position of function?
Position of safe immobilization is 30 degrees of wrist extension, 70 to 90 degrees of flexion of MCPJ, and full extension of all the four fingers IPJ with the thumb in palmar abduction and flexion. The second question is function, sir. Function also would be the same. Position of comfort is the opposite.
No, what is the essential difference between these two? Why there are two different terms, position of mobilization and position of function?
Because in a position of immobilization, sir, the IPJs are straight, like fully extended, whereas in position of function, as we can see in the second picture, they are around 0 to 5 degrees, 5 to 7 degrees of flexion of the IPJ is there.
So which
Function
conditions
is more in
which conditions you will contemplate using a position of functional splint, and which conditions you contemplate using a position of immobilization?
The position of function splint I will give, sir, when we want to encourage the patient to start moving his fingers, say following trauma, if there is just a wound over the forearm, flexor or extensor aspect, but we want the patient to continue using his fingers. So position of function is given in those cases. Or after surgical management of post-burn contractures, we want to restart the active physiotherapy. In those cases also, we start with these splints. If we don't have a dynamic.
Basically, it's a permanent splint, position of function, when we don't expect any complete recovery, even after doing so much of manipulations, you don't expect a full recovery. So you want that patient should have at least a glass holding position, where you need the IP joint flexion. So in those cases, you give a position of function. And where you just need to immobilize for the temporary period, where the patient will recover completely after your manipulation or after the intervention. You do those position of immobilization splint. So what is the purpose of a splintage? How it helps?
Purpose of splintage, sir, splintage basically they help in preventing the particular joints to be in a position where edema can maximize. So it helps in preventing edema to settle, which in turn can lead to contractures over those particular joints, such as in a hand or in a elbow. We usually give them an extension. So it prevents contractures, as well as it promotes dynamic splintage will help in promoting the function of the other fingers while immobilizing a joint. Those are also possible.
Keeps the muscular tenderness in it in a very elongated state.
Excursion is maximized.
Excursion maximized. So go ahead with the other splints also.
Yes, sir. The third splint in the top row, it is a dorsal block. It's a digital gutter splint, sir, where the PIPJ is free and the DIPJ is in splinted position. So it most likely it's used in cases of mallet fingers when we are conservatively managing for the first 6 weeks in the first stage 1 of mallet finger. Also, if we are managing a swan neck deformity following correction, we can go with no, not for swan neck deformity, only for mallet, sir, because PIPJ is free in this splint. Should I proceed with the next one, sir?
Yes, please.
The fourth splint in the top row, sir, it is a dynamic cock-up splint, which is involving all the fingers. There are separate sleeves for each of the fingers. So the wrist, it keeps the wrist in around 30 to 40 degree of extension. And here we can see that all the MCPJs are in flexion, 70 degrees, 70 to 90 degrees, and all the IPJs are in extension. So these sort of splints we give when we in cases such as post-burn contractures following once the wounds have healed, when we are encouraging the patient to start physiotherapy. Secondly, following extensor tendon,
radial nerve palsy,
extensor tendon injury, where we want to begin physiotherapy following 3 to 6 weeks.
Quickly tell me the advantage and disadvantage.
Advantage is that, sir, it is a dynamic splint. So we can start with passive MCP extension at 3 weeks in case of radial nerve palsies. And disadvantage will be
The
Does it
patient
not
utilize,
because
yeah.
Yes, sir.
Patient utilizes it for 24 hours. What will happen? So it is used with a cushion.
Nighttime we should have static splintage, sir.
What
Not
is the reason? What is the reason behind it?
because at night time when the patient is sleeping, there might be, because these are in the control of the patient. So once at night, like there is a possibility that the fingers will not be maintained in that position. So that is why. So should I proceed?
Go ahead.
Sir, in the lower left side, it is a aeroplane splint, which is used for post-bone contractures of axilla. It has kept the shoulder at around 100 to 9. In this photo, it is kept around 100 degrees of shoulder abduction, elbow extension, and the hand is neutral. So it is used in cases of following coverage after release of post-burn contractures of axilla, or in brachial plexus surgeries also can be used, sir. Following
brachial plexus, what after what surgery? Following brachial plexus injury.
Sir, some people can like to keep this position following
no, if you do a muscle transfer, like say for example trapezius transfer.
Trapezius transfer for shoulder abduction. Yes, sir.
Shoulder abduction. So what are the disadvantages of this?
Sir, it is slightly uncomfortable for the patient, especially in pediatric age group, sometimes to keep this, maintain this position. There might be, if not adequately padded, there might be some pressure source which can be created at the bony prominences, such as the medial epicondyle or even over the wrist. It is a static splint, so it will it will not allow any movement of the elbow. It does not have a dynamic component attached.
Any possible effect over the motor function or sensory function?
Paresthesias can be there if ulnar nerve gets entrapped, sir.
Stage, prolonged stage over a period of time.
Brachial plexus also, actually, sir. If it is not in this angle, but it is more continuously.
Continue.
The last picture, sir, it's a multiple compression garment, sir, depending on the site of the site affected. So the first one is the compression garment that we usually give following post-burn, following burns, including the facial burns. The second one is like a chin strap, which is usually given in the late stages after management of neck contracture, or in the
post-operative cases and after fat grafting and all, we can give compression.
And then there are different types of trunk and extremity compression garments, including for upper limb and lower limb, depending on the site involved. So other than post-burn contractures, sometimes we can also encourage compression garments in following lymphatic malformations or venous malformations when we are managing them conservatively. The mechanism by which they act is that they occlude the vessels, the microvasculature, which creates a hypoxia in the local tissue, which in turn basically stimulates collagenase to promote more collagen formation, organizes them into more bundles. So it helps in management of hypertrophic scar for post-burn cases. They also decrease the venous hypertension in the tissue, raise the temperature in the tissue. These are and decrease the edema as well. So these are some of the mechanisms by which they help, especially helpful in hypertrophic scar to prevent hypertrophic scar, also to manage hypertrophic scars because they help in providing that pressure to get the scar down to the level.
Amount of pressure can it be?
It's around 25 to 40, sir. At least it should be 25 millimeter mercury. But should not cross 40. Or it should not be less than 25.
Yes, madam.
What is the type of collagen that is there in hypertrophic scar and keloids?
Type 1 collagen is more, ma'am.
In the normal or in the abnormal?
In normal, ma'am, type 1 collagen is more, but in hypertrophic scar, type 3 is there and type 1 is less.
Yes.
Type 1 is
Okay.
less.
And the arrangement pattern?
Ideally,
When you
ma'am,
see it,
in a supple scar,
when you see it under the microscope, what will be the difference of arrangement of collagen bundles in a normal skin and in a hypertrophic scar?
in a normal skin, ma'am, there will be parallel wavy bundles, which will be symmetrically found all over equally distributed, along with beside which the capillaries will be there growing and the cells will also be interspersed. But in hypertrophic scar, there will be disordered crisscross network of all these collagen fibers and they will not be parallel.
Okay.
Ma'am, actually, time is up, ma'am. Can we go to the next session?
Okay. Okay.
Describe this case.
What is the
Dr. Gopika.
Depressed.
What do you see?
Ma'am, it is a lesion, skin lesion measuring around 5 into 6 centimeters in size with irregular margins rolled.
What is conspicuous there? It is a conspicuous, something is very striking on seeing it.
The edges, ma'am.
The
edges are rolled out edges.
Yes. And the central area seems to be
depressed.
Is it depressed or it seems to be healing and the periphery is spreading?
So there is a name for it.
So
to describe this condition, there is a name. Have you visited the countryside ever? Especially post-harvest seasons.
No, sir.
Field fire.
What are the types of, what is your diagnosis, likely diagnosis?
Sir, ma'am, it's a healing wound following, like sir said, fire.
That is, from the look you see, it is a slightly older individual and the lesion is in a peculiar zone for which your likely diagnosis is written there.
Not
An
sure.
older
Not
An
sure.
older individual with a lesion arising above a line drawn from the tragus to the angle of the mouth.
Basal cell carcinoma of
Likely. Okay. A differential diagnosis. And field fire is a type of? What are the different types of DCC?
Nodular, infiltrative, pigmented, morphiform.
Okay. So you have a different classification. Field fire is one form of. How will you confirm the diagnosis?
We'd like to do a tissue diagnosis, ma'am, with a edge biopsy, which would confirm the basal cell carcinoma.
And if you are, what will be the pathognomic feature?
In microscopy, ma'am.
Yeah,
Yes.
microscopy, what will be the finding?
In pigmented lesions, ma'am, there will be
In general, the BCC, what do you see invariably?
basaloid types. Basaloid.
Basal, just qualify it. Basal, what is that appearance?
Basaloid.
Basal, just few more words.
Not able to recollect, sir. Basaloid.
Early shading, early shading.
Palisade.
Yeah. So how will you manage it?
Sir, we'll go ahead with a wide local excision of the skin lesion. And in
How
this
wide?
case, we can take 0.5 to 0.6 centimeter excision can be done in this case, as it is on the face.
From where? From where?
from the periphery, sir, of the
Normal
lesion.
skin.
From the palpable margin.
Palpable margin.
The palpable margin, go for wide local excision. So in this is the
In
surrounding.
BCC. In BCC, is a lymph node involved?
No, ma'am. Usually not
Why?
involved, ma'am.
Why?
They are locally invasive.
Lymphatics are all basically destroyed. So the lymphatic spread is prevented because of.
If the lymph node is also there, what do you suspect?
Malignant melanoma.
Or common?
Squamous cell carcinoma.
If there is a superadded infection also, there can be lymph node involvement. Okay. After excision, how would you like to resurface this lesion?
For that, you need to know about the depth also. How much depth will go?
Yes.
Because the wide local excision doesn't involve the surrounding. Sorry?
So we should be taking one.
Apart from the surrounding, around the lesion, there's a depth also. 3-dimensional. Yes. So how much depth will you go?
One layer below the involved layer, sir. So
okay.
So in this case, sir, if only the my depth would be just above the SMAS layer, sir.
Yes. What do you expect?
So, sir, we would like to do a wide local excision with a 0.5 centimeter margin around the lesion up till the SMAS, sir. Followed by
reconstructing the
reconstruction.
We'll go ahead with a full thickness skin graft.
Okay. Can you get some additional help perioperatively? Can you send the specimen for a frozen
Section
for knowing the clearance?
Yes, ma'am. We can send the sample for frozen section. We can get help from the pathologist and ensure the margins are clear or not.
Okay. If the margins are clear, you are willing to research with the skin grafting.
Yes,
Suppose you are involving up to the muscle layer also. Then
we'll have to give a flap coverage.
Even if muscle layer is involved, ma'am, like we did not.
Can you apply a graft over the bone?
No, ma'am. And if periosteum is not intact, then we cannot apply.
Yes. You can go ahead and do a graft even if the pericranium.
Yes,
if the pericranium is intact, will you be able to do a graft?
Yes, ma'am.
What would you prefer, a flap or? In these malignancies, if you are having an option of graft and flap, what would you prefer?
Flap, ma'am.
A graft or a flap?
Flap, ma'am, since they might
Why flap? Why graft? Why flap? Why graft?
Flap carries the in case this turns out to be a high grade malignancy, which is not that likely in this case of basal cell carcinoma. Then if they require radiation, some of the high grade lesions require. So in those cases, we would prefer to have a flap. However, in this case, because since it's a PCC, so we can go ahead with the graft as well, respecting the anatomical territories. This is the lateral side of
What is the advantage of putting a graft? If you are giving a graft, as you said, if you give a flap, if you require radiation, flap is advantageous. If you put a graft, what is the advantage?
Monitoring for recurrence, ma'am.
No, ma'am is asking advantage of
local
graft.
recurrence is early. Yeah, advantage of graft is early detection of
recurrence of the lesion.
Local recurrence. Suppose there is a local recurrence, you will be able to detect it early. Okay.
Early.
Suppose you have to put a flap, what is your option here?
Not the whole of it will be covered.
Something from the leg?
Most likely the
posterior auricular artery.
Flap.
Qualify that. Can
Yes.
do that.
Yes, sir.
Qualify. What was the extended?
Extended superiorly based posterior auricular.
Superior. Extended posterior lateral flap with a V2Y type of design. But the disadvantage hairline will come further.
Yes, sir. Will not.
Yeah, distortion of the hair. That will be the only disadvantage.
If the histology report is basosquamous carcinoma, what will be your approach?
Sir, basosquamous is more high grade, so we would have to go ahead with a 1 centimeter margin. of 1 centimeter. So in that case, defect would be more.
Sir, time is up, sir. Can we go to the next session?
Yes, please. Yes. Go ahead.
Yes, please.
Questions are written. Answer accordingly.
Yes, sir. This is a middle-aged man with a ulceroproliferative lesion involving the lower lip. It is involving more than 60% of the lower lip over the starting from the over the left side of the lip. So most likely squamous cell carcinoma involving the lip, cutaneous as well as the mucosal part of the lip is involved in this. So I'll be counseling the patient regarding the excision and the treatment options as well. So after the wide local excision, there is issues will be related to oral competence, speech, and about the treatment options, reconstructive options, most likely he will require a free flap coverage. So I'll counsel regarding the that as well, the surgical complications and requirement for a radial artery forearm flap. For that, again, I'll counsel the patient regarding the scar which will be on his forearm after the surgery, and all post-operative management, the requirement for radiotherapy, chemotherapy.
So how will you confirm your
Vishal.
diagnosis? Yes. Go ahead.
Sorry, Dr. Vishal is also joined. He may also join the panel.
Yeah, please, Dr. Vishal.
Yeah. You said something about radial artery forearm flap. That will be your first choice. Would you like to do some test for it?
Allen's test, sir.
Yeah, how do you do that? How do you perform the Allen's test?
Sir, we feel for the pulsations of both the radial and ulnar artery, and we occlude both of them together. Then we ask with the arm, usually the elbow is flexed, the hand is raised, and then we feel the pulsation and occlude it. Then we ask the patient to make a fist and open the fist around 15 to 20 times, following which we will release the digital pressure over the ulnar artery to check for the capillary refill in all the fingers as well as the palm. So there'll be a flush, capillary flush, the blood which will be visible. It will be visible. Ideally, normally it should be visible within 2 to 5 seconds, beyond which it would be considered compromised.
Why you have kept only one option, radial artery forearm flap? Is there any other option in this flap for this treatment of this patient?
Any other free flaps also we can do, sir. We can.
Which free flap will you choose?
A small suprafacial anterolateral thigh flap can be done.
Why only suprafacial? Any added advantage with the suprafacial?
It's suprafacial anterolateral thigh flap, sir. It is more pliable as it is in the lip. It would be advantageous in with respect to the pliability of the flap. Aesthetically, so we can mold it accordingly. Aesthetically, it would be better, less bulkier.
In both the cases, sir, we will also try to take in ALT, we will take a part of TFL tensor fascial lata graft, or in radial artery, we will take palmaris longus to create a sling, which would be required in this case because the competence will not be present following excision. So if possible, we'd like to do the same in the
staging. You missed the lymph node status. Lymph node status is not clear. Would
Yes.
you not like to do the staging of the tumor?
Yes, sir. We'll
Clinically, we would be examining the the neck for all the levels of the cervical lymph nodes. And we would also like to confirmatively stage it by doing a CCT of the head and neck, which would give us an idea of the lymph node status, sir.
Dr. Satya, anything you want to ask?
Yeah. Tell me other similar type of flaps where we can expect a thin amount of skin from any other part of the body.
Parascapular flaps are medial sural artery perforated flap. Also, the skin would be thin.
From the upper limb,
upper limb, lateral arm,
medial or lateral arm flap.
lateral arm.
Any local flaps you can plan?
Sir, in this case, but sir, in this case, like more than 80% would be of the lower lip would be involved. So the better.
If we take local flaps, sir, it will result in microstomy.
And secondly, sir, this patient most likely will be requiring radiotherapy following the surgery. So that
Can you
might
contemplate some local option which will result in macrostomia?
What is
You know what gate flap? What is gate flap? Bilateral gate flap.
Johansson's too.
So Gillies flap both side.
Gate, G-A-T, gate flap, bilateral gate flap.
Not sure, sir.
Yeah, it's based on nasal veil artery. Both the sides you can take, and enough good amount of mouth opening. There's a result in macrostomia. Very big amount of mouth opening will be there. So, what will be your post-operative management?
Post-operatively, sir, immediate post-op, the patient would be in the ICU. So we would be following extubation. We would be encouraging oral suctioning and and we would be educating the patient as well as the attender regarding the oral hygiene that needs to be maintained. From post-operative day 3, we would be beginning chest physiotherapy and steam inhalation as well. Patient, depending on where the flap, what flap has been taken, like in this case, if radial artery forearm flap is there, then we would also be keeping the upper limb in elevation. On post-operative day 5, we would be doing the first dressing of the before that, sir, first 24 to 48 hours, we have to monitor. In the first 24 hours, every hour, 1 hourly to 2 hourly, we would be monitoring. We'd be looking at the color and the bleed of the flap on scratch. Following 48 hours, we would be decreasing the frequency to around 4 to 6 hours till around for 2 more days. And then once in 6 to 10 hours following that. So depend.
What about feeding?
Will you feed
What
this
about
patient? How will you feeding?
Yes,
How will you do?
for nutrition, sir, initial post extubation, for after 4 hours of waiting, we would be giving a test feed, which would be clear liquid water for around 50 ml. Following that, if there's no aspirate, we would be starting RT feed, which would be a high protein, initially liquid diet. Then gradually we would be progressing it to a high protein liquid diet around from 150 to till 300 ml third hourly. And we here, sir, we usually keep the RT we will be keeping it for around at least 5 days, 5 to 7 days. And if everything is fine, then we'll first clamp the RT and encourage the patient to start taking water. If he's able to do so, then we can remove the RT after that.
What about heparin prophylaxis?
Ma'am, in our institute, we usually don't give heparin following the primary surgery. Only during after re-explorations, we usually give a heparin infusion. We give a heparin bolus 10,000 immediately after the removal of the clamp following re-exploration, and then we usually keep them on an infusion for at least 3 days, preferably 5 days, which is around 5,000 units in 500 ml of NS IV over 12 hours.
Okay.
Immobilization of the head and neck, maintaining the temperature, maintaining the urine output. These are all very important vital things. Any following any flip-flop surgery, you have to be very careful. Any other questions from other examiners? Please go ahead.
It's not used. Sir, I'll be documenting regarding the biodata, the name, age, sex of the patient, and since it is the lower limb, I'm assuming that it is post RTA. So I'll ask for the mechanism of injury. Mechanism of injury will be noted, the time of injury, place of injury, as well as the associated injuries along with it. Along with that, a brief history of the person's comorbidities and medical history, relevant medical history, allergy history will be taken and documented. If it is an RTA case, I will document as an MLC certificate will be documented as well. So in this case, the wound on inspection, I'll be documenting the size of the wound over the medial aspect of the right lower limb on the upper third of the leg with an implant exposed. Surrounding skin appears to be normal. No signs of infection or inflammation is there. Peripheral, it doesn't, no ischemic signs as such, no dryness of skin. We'll document the peripheral pulses and sensations as well.
So if the patient has already, if the X-rays provided, then we would be documenting the X-ray finding as well.
And also regarding the previous surgery which was underwent, the place where it was done. If we can, we'll get the details of the implant used.
Did you talk about the vascular status?
Yes, sir.
What will you document in the X-ray? Do you see in the X-ray?
Yes, sir. We documenting that there is a tibia fracture, tibial most likely there's a we can't really.
What has been done? That is visible there.
Reduction and internal fixation with plate and screws has been done, sir.
Yeah, you will document the plate. You will document the number of screws.
Number of screws, plate, and plate also how many holes are visible. If possible, we would be documenting it. T-shaped plate.
What is the primary problem in this patient? As a plastic surgeon, what do you have to?
We most likely would have been called for the coverage.
Yeah,
of the
because the plate is exposed.
Yes, sir. Yes, sir.
And is the bone osteomyelitic or not?
Sir, look, from the photo which has been given clinically, doesn't look, sir, there's no any sign of any seropurulent or purulent discharge. There's no signs of any surrounding skin inflammation. The amount of bone that is also visible in the photo, we can't really, it doesn't look like lusterless, or there's no signs of chronic osteomyelitis as well. In the X-ray,
So will you take any help of the orthopedic colleague for this patient? If you need to.
Yes,
what will
sir.
be your plan for this patient?
I'd like to take a orthopedic consultation, sir. We ask them from their side if they have any intervention. But most likely, sir, in this case, doesn't look like there are any osteomyelitic features. Also, not in the X-ray, sir. So I'd like to go ahead with the coverage of the defect with the flap. So
Which flap?
so we don't have a lateral view of the photo, so don't really know the status
No,
of
what
this.
will be your first plan? What do you think as a plastic surgeon? What
Firstly,
flap you
sir,
will choose?
as we can see here, there is a distal defect, and there's also proximally there is a defect. So I have to first define the defect. So to define the defect, we have to most likely set the skin bridge in between both the skin
Is it
bridge.
healthy? Is it healthy?
No, it is not healthy, sir. So I'd like to
What will you do?
we have to excise that part, debridement and
Debridement.
pressure of the margins of the wound. So following that, sir, it most likely will be a defect over the anterior proximal aspect of the right leg.
With implant exposed.
With
So
implant
what will be your first plan? Say you've done the debridement and it is a 5 by 5 centimeter defect. Now what? With bone exposed, with implant exposed.
So we'll go ahead with a medial gastrocnemius flap with a medial
So you will go
gastro.
with a muscle flap.
Yes, sir.
Why not a local flap? What can be the other options?
Sir, medial sural artery perforated flap can also be done. Or a local.
You would like only a muscle or a musculocutaneous?
Musculocutaneous, ma'am. But first, I would like to, if possible, fasciocutaneous flap would be a better option here. So in that case, if possible, go ahead with a
Superiorly based, inferiorly based, which side?
superiorly based
transposition flap from the medial aspect of the defect.
Will you be able
Why
to
not
get
the
a
lateral?
superiorly based?
Yes.
Would you like to hear from the orthopedician whether they want the implant or whether they want to remove the implant? Or whether you would like to know whether there is an infection in the implant or not?
Yes, ma'am. Before proceeding with the flap soft tissue coverage, we will discuss with our orthopedics colleague regarding the management of the further management of the fracture as well as to rule out osteomyelitis.
Will your planning of flap differ according to whether they intervene or not? Suppose the orthopedician says, I want to explore again. What would you prefer, a muscle with skin grafting or a musculocutaneous? Or a fasciocutaneous? Which would you prefer? He says, I want to again re-explore or I want to remove the implant. In that case, would you prefer a muscle with skin grafting or a musculocutaneous or fasciocutaneous flap?
Sir, ma'am, if possible, we would like to raise the flap before together. Both the teams operating, we'd like to raise the flap before they intervene. So in that case, we can go
No,
ahead.
you misunderstood the question. Ma'am is
The
asking,
question is
you have to
whether it is
re-explore
muscle
again.
skin grafting or a musculocutaneous or fasciocutaneous flap, which is
In
better?
that case,
for
ma'am, muscle and grafting. Muscle flap.
No. If you want to again explore, what is your option? A muscle with skin grafting or a flap which has a cutaneous cover over it?
If we have to intervene again, then skin component it will be easier to raise the flap and put it back again.
Yes, you would prefer a musculocutaneous or fasciocutaneous?
The basic principle is replace like with like.
So must be.
So if there is a future plan of re-exploration, then suppose there is a big bone defect or like that, you want to do some bone grafting later on, you want to raise it and then put it back. So Apsicon is a better option. So gastronomy, which type of lab?
Type 1, sir. That is 9.
Which
Has
supplied
one
by?
single dominant supply.
Name of the vessel? Name of the vessel?
Medial head is by the medial sural artery and lateral head is by the lateral sural artery.
How many sural arteries are there?
3, sir. There's a median sural artery as well, sir, which comes directly from the popliteal artery. And these two are also coming from the popliteal artery.
So what does median sural artery does? Supplies any structure which you know?
Sural nerve. The
plantaris also.
So can you plan the incision if you want to do a gastronomist lab here in this case? Where will you put your incision?
Midline incision posteriorly, sir.
Any specific reason for that?
Basically, we are taking only the medial head till gastronomist lab. So
It's a high velocity injury. If any case, the
away
muscle
from the zone of trauma, yes, sir.
away from zone of trauma, if the muscle goes, you have a backup option of
Yes.
the fasciculus flap in future. Good. Any other questions for other journalists?
Well, if the panelists are finished, can I have 2 to 3 minutes?
Yes, sir, please.
Sir.
Yeah, thank you. Madam, you want to complete fast? Any question
sir.
left, madam, panelist?
Please,
No,
sir, go
sir.
ahead.
No, sir.
Madam?
You can
Yeah,
go ahead.
thank you so
can go
much.
ahead.
So thank you very much. I have few observations. The panelist has done most justice to the students and they have asked most of the questions. I have nothing to say. It has been almost complete. But to start with the long case, I have to ask you regarding the history. The neurological status in burn patients, especially convulsion, all these things has to be asked. And as far as the planning is concerned in plastic surgery, the planning in reverse, finding out apparent and true defects, and comparing to the other side or to another patient of similar stature, this all has to be done. Yes, the examiner will definitely like to have this. So as a student, you should have these things ready. And that should be always a true and true defects in 3 dimensions and template must be made out. And you should mention about the donor areas, which you have not shown, you know it, but I think these have to be important as far your exam is concerned. Regarding the next lymphedema, the stages you have done in foreign countries, they don't have filarial lymphedema so much because they don't have the filaria vachuria Bancrofti. So in India, it is very prevalent and most common. This is what you have shown in these photographs. For as far as our Indian classification, Dr. Chatterjee, he has classified into 4 stages, stage 1, 2, 3, 4. First 2 stages, Chatterjee. So this has been, Dr. Chatterjee, this classification been acceptable by Lymphology Association of India and International Association of Lymphology also. So I am also a duty member of that association. That's why I could be able to know. For the students I am talking of, because we do ask in the questions, also the management also is valued on the classification. So class 1, stage 1 and 2, it is the first stage is when you lift it up, it went up. And second is it went up in the night when the patient lifts up in the next morning. And there is a pitting edema. And in third stage, the edema don't goes. And fourth will have the complications. So I'm not going detail of it. But the lymphedema, that also matters. Okay. That also, and the 4-stage in this case do not have a complication like ulcers, but elephantiasis has developed, and that will go to stage 4 of Indian classification. As Nagpur classification we have for the cleft lip. Likewise, I think students should know about it. And regarding the fracture zygoma, always the fracture zygoma is associated with orbital injuries. So you ought to see it. And while you are asking of the photograph, management is asked, you have to talk about the occlusion. On that photograph, you have to, you must tell that in the exam, I need to have more examination to take detail about it. Regarding the splint, rightly, I think most of the answered, but the only thing is that you have to know 2-3 conditions, not one condition for one splint. 3-4 conditions you ought to know about the splints being used. BCC, I don't think I have to speak about much. It has been nicely discussed. Regarding the counseling of the patients, we talk about the form also. Function has to be also counseled to the patient. How much patient is going to get the functional loss and how much he is going to gain. That is very much important in counseling, because the patient will ask that you told everything will be okay like normal, but I am not getting back. So that is very important as far as the counseling is concerned. And documentation, all these cases of trauma are medical legal cases. So officially in any institute, maybe all in institute or any medical college, one X-ray of this patient has to be kept in your department as a further requirement of the medical legality in the court of law. So as far as documentation, this is very important. And always keep an options of your management. Don't get nervous. The examiners are very tough examiners sometimes, but they are friendly to you when you answer very smoothly and softly. Do not get too much either excited to answer or be stick to any question answers. You have to have a multiple options for anything that already been told. I think these are few things I have observation. So thank you very much for giving me this opportunity of speaking something on this. Thank you so much.
Thank you, sir. Thank you, sir, for this enlightening comments. Any questions from the delegates or the faculty?
Dr. Umar, can I ask a question?
Please.
Yeah. About the long case for students, have you read anything? Local flap is used correction of contracture axilla?
1 minute, Dr. Farooq, please 1 minute. There is some noise coming on. Please continue.
My question is for the long case.
Dr. Likita, can you mute?
Have you read anything about the local flaps used for correction axilla?
Local flap. Yes, yes. Local flaps like in terms of
1 minute, beta. 1 minute. Just 1 minute. 1 minute. Just mute. That noise is coming on. Dr. Likita, can you mute him?
I didn't have access, sir. I'm not able to.
तर समजा हे पेनफुल वगैरे आहे हे बी काढायला सांगू शकतात सर है ना
Sushil, will you please mute yourself, please?
दाखवून देऊ त्यांचं डिसिजन
Dr. Sushil, please mute yourself.
आता समोरच येऊन ना इथे राहता ना तुम्ही जास्त दूर राहत तिथे सोडा समोर ठीक आहे
ओपीडी मध्ये
हो ठीक आहे हे समोर वॉर्ड सोडायचं समोर ओपीडी आहे
You can. You are this thing now. You can mute him.
No, sir.
You must not be.
Access
You must not be knowing.
Today, sir.
Okay.
Now he's muted.
Let us continue then. Let us continue then. Yeah, please. Ahana and Gopika, please go ahead.
Yes, sir. Sir asked about local flaps possible for post-bone contracture of axilla. So that can be like a square flap or a 5 flap. Loco-regional would be parascapular or scapular or a thoracodorsal artery perforator flap.
And if the dome is not involved, we can use a propeller flap as well. If the dome is not involved.
Anything else?
So,
sir, you want to add something?
I will ask you a question. Who is the mentor of the Plastiquest? Because that will answer your question. That will answer my question. Who is the mentor of Plastiquest?
He is not
there. Yes.
Lakshmi Madam, sir.
So, okay, so Dr. Bhattacharya, sir, and the.
Oh, sorry.
So, okay. So you need to read the use of lateral thoracic flap in correction of post-mortem contracture of neck. It was published in the British Journal of Plastic Surgery long back, and it's a very useful flap. So we will request all Dr. Bhattacharya, sir, to throw some light on this flap, and that would be great for us. Thank you.
Thank you, sir.
Yes, we'll take it later on. Just a minute. Any other questions?
Yeah. No, thank you, Vinay.
Then sir will talk at the last comment will be from the Bhattacharya, sir. Any question from any other faculty or the delegate? If no, Bhattacharya, sir, for the last comments as well as about the flap, Dr. Farooq is talking about.
Thank you, Dr. Umar. First of all, I'll address to the students directly. Sometimes, you know, you have to use some words which are expressive and impressive. That you need not speak the whole sentence, and that impresses the examiner. For example, how the contracture develops. You have discussed enough. Examiners are satisfied. But you should ultimately say the position of comfort is the position of contracture. Suppose there is an elbow burn in the polar aspect. So gradually the patient is comfortable every time with little flexion. If it is not splinted or adequate physiotherapy is not given. So the flexion of contracture is the flexion of comfort. Ultimately it becomes like this, acute contracture. Okay. So that's one point.
Yes, sir.
So whenever you use, I'll tell you something else also. And then when do you do excision release? Okay. When you have already answered, but additionally, when there is too much of hypertrophic scar across the contracture, because if you do an incision release, on either side, that hypertrophic scar hangs. Release is complete, but aesthetically it looks very bad. Or on the table, you feel that you want to remove a wedge excision to make it, you know, in continuity. And second thing is an unstable ulcer across the contracture. Rest you have already said. When there is a contracture of the neck as well as axilla, this question was asked. Suppose acute contracture of neck and axilla. Will you release both together? The answer is no. Why? You release the neck contracture first because next time intubation will be easy. Second thing is, we always give brunt of physiotherapy to the patient following release, whether you splint or don't splint. Of course, we splint. So if you give two major joints to the patient, they don't do physiotherapy adequately. And ultimately, there is recurrence in both. So many times patients ask you whether can it be done all together. Then you have to explain this, that it will have difficulty for you to do exercise and maintaining the position of both axilla as well as neck. You do yourself, you will realize. Okay.
Yes.
Third thing is, when you said that you will inject tumescent in your institute, it's fine. Only thing you have to say is that it helps in hydraulic dissection. This is the term. It creates plane between the scar, contracture scar, and the normal tissue.
Yes.
So even with finger dissection, with the help of your instruments, it becomes very easy. So the word is hydraulic dissection. When there's a question of Z-plasty, why do you do Z-plasty or fishtailing rather at the margins? Now, fishtailing is because the contracture happens in a picture frame way. Picture, this is the word, picture frame. contraction. So when you do these angles of the picture frame, there you do mainly the
Fishtailing.
fishtailing. Of course, additional also you can do, but the principle is this, because the contraction is occurring in a fishtailing. Dr. Bhatt asked me to talk about the lateral thoracic flap, which we published long back. And it is a very useful flap because in this particular phase, for example, you have a lot of tissue. Some are with posterior to the exact contracture, rather the posterior axillary fold and down below. So the scar was looking hyperpigmented, but relatively soft. And it is a type of fasciocutaneous flap. You include the fascia. So because fascia gives additional blood supply to the tissue and you don't lose anything. So you have the advantage after release of the contracture, you have the advantage and liberty to keep a wide base and plan according to the requirement of the defect. So you have a long flap. That's the main advantage. And because you are keeping a wide base, you can always, if need be, do a back cut. It is based on the vascularity, which you have already explained. We all know about the lateral thoracic vascularity. But that's the major advantage, that you have the liberty of a long flap and you have the liberty of a back cut if need be. The other thing is, in this particular case, about the local flap only, you must know about the bipedical release and the principle of it. This also we published, in fact. And bipedical release gets the benefit of graft as well as flap, because across the joint, whether it is PIP or axilla, if you know how to do bipedical release, the flap goes into the axilla across the joint and graft on either side. And that graft contracts in just opposite direction. So they neutralize the contraction effect. So graft contracts superiorly and inferiorly, and the flap is in the center. And so it's a great advantage, and it's highly vascular, and you do not require long splinting, and you can initiate physiotherapy much, much earlier. And there is hardly any chance of recurrence. Regarding lymphedema case, I asked you why sole is not affected. Because the plantar fascia is strongly adhered to the first layer of the plantar muscle, the flexor digitorum brevis, the abductor digiti minima, and abductor hallucis, and subsequently to the deeper muscle. So, and this is number one. Number two, there is very little lymphatics on the sole, inside the sole. So one is it is adhered to the muscle. Second is less lymphatic, and third thing is patient is walking, so he is pumping out whatever is lymphatic stasis is there, and therefore seldom the sole is in. I asked about lymphangiectasis. It is nothing but dilated lymphatic vessels. It is totally different than lymphedema. It's a relatively rare case, and here the result of excision, just few elliptical excisions and removing the lymphangiectatic channels is like a network, if you see. And intraoperatively, so much of lymph is there that if you compress, it comes like a fountain, which never happens in lymphedema otherwise. And this lesion, as I said, it is a compressible lesion manually on the table anytime, not like lymphedema. It's not pitting or non-pitting business. It's totally compressible because the lymphatic fluid goes inside the lymphatic channels. So that is the difference between lymphangiectasis and lymphedema. Regarding basosquamous carcinoma, if the histology is basosquamous, treat it as squamous, not basal.
Yes.
Okay, so it's a squamous cell carcinoma. And the last comment which I want to make is, don't repeatedly say in the examination, in this case, in this case, in this case. It is this case. We are discussing this case. It's no theory. So never keep on telling in this case, in this case. Okay. So I think these are the few suggestions which I wanted to give. Thank you for giving me the chance and I could contribute something.
Thank you so much. Thank you, sir.
Sir, can we do TDAF flap also? Is there any
Yes,
possibility for
yes.
that also?
Yes.
We have done a few TDAF flap for the axillary contracture release and rest we have grafted.
Yes. So it can be
Any
a
comment?
combination of flap and graft. It's not
Yes, sir.
always
In the
either
axilla,
graft
you
or
need the
flap.
flap. Yes, sir.
So think about the post release defect, and depending upon the location, for example, in the axillary fold, lot of vital structures are there where you need a flap many a times. And the third thing is sometimes in contracture axilla, people try to do too much of abduction on the table. That causes some neurological problem. So you have rightly said about 110 to 120 degree abduction. Thank you.
I request the panelists